Okay, so your task is to teach your ST1 regarding the perineal tears and specifically how to repair 4-degree.
Hello.
जी जी स्टार्ट करो. Your task is to teach ST1.
Yeah. Assalamu alaikum. My name is Dr. Zarona. I'm one of the SRs here. What is your name?
Continue.
Sorry?
Continue करो. ठीक है.
Okay. Okay. So what is your name? Okay. Sadia, I've heard that you want to learn about perineal tears. Is that true? Okay, I'm very happy that you're keen to learn. So why are you interested in perineal tear? Okay. So today together we're going to learn about perineal tears. In the end, I'm going to tell you about some study materials and you can also give me some feedback, okay? Okay, so first of all, I'm going to tell you what are perineal tears and what are the classification of perineal tears. So perineal tear during childbirth are classified into 4 degrees. The first degree tear is a superficial tear that involves the skin of the perineum and vaginal mucosa. The second degree tear, it extends a little deeper, involving the perineal muscles and fascia. The third degree tear is subdivided into 3A, 3B, and 3C. The 3 involve less than 50% of the external anal sphincter. The 3B, more than 50% of the external anal sphincter, and 3C involves the internal anal sphincter along with the external anal sphincter. And the 4 degree tear involves the anal sphincter and the lining of the rectum. Am I clear? Okay,
Yes.
can you please?
Yes.
Can you please repeat? Okay, very good. You're a very quick learner. Okay. So do you want to ask anything?
Yes, tell me about the 4-degree perineal tear. I'm confused how we repair it.
मैम स्क्रीन शेयर करेंगे?
हाँ, ये शेयर नहीं हो रही. Wait.
नहीं.
Okay. Now?
No, ma'am. Okay. Okay, so you want to learn about 4-degree perineal tear repair. Okay, so first of all, what materials do we need to repair the 4-degree perineal tear? The operating theatre with good lighting, sterile perineal repair packs, sterile gloves, gown, mask, and eye protection. The sutures that we need is 3040 polyglectin vicryl or monofilament monocryl for anal mucosa. And obviously, we need a team that involves obstetrician, anesthetist, scrub nurse, and anesthetist. Now I'm going to tell you the steps by which we repair the 4-degree perineal tear. The first step is recognition and assessment. After every vaginal birth, perform systemic inspection and digital rectal examination. Identify a 4-degree tear, full thickness tear involving anal mucosa, internal anal sphincter, and external anal sphincter. Obtain informed consent and confirm adequate analgesia and anesthesia. Preparation, transfer to operating theatre for optimal lighting and asepsis. Position patient in the lithotomy with boot stirrups. Prep perineum and vagina with antiseptics and apply sterile drops. Insert indwelling urinary catheter for continuous bladder drainage. Repair should be performed under supervision of experienced clinician in theatre. Classification and planning. Classify the extent of injury and assess for associated tears, that if associated with vaginal, cervical, or labial tears. Plan repair sequence and confirm all materials are ready. Repair of anal mucosa. Repair the torn anal mucosa first. Use 3040 polyglectin vicryl or monofilament monocryl sutures. Continuous or interrupted technique can be used. Avoid figure of 8 sutures. The knots in the anal lumen for mucosal repair. Knots in the anal lumen for mucosal repair are standards. Repair of internal anal sphincter. Identify and grasp internal anal sphincter ends with Allis clamp. Repair internal anal sphincter with interrupted or running suture using 30 PDS or polyglectin. End-to-end approximation is standard. Internal anal sphincter should be identified and repaired separately. Repair of external anal sphincter. Identify and grasp external anal sphincter end with Allis clamp. Choose technique based on experience and muscle condition. Overlapping technique, overlapping muscle ends and suture with 3-0 PDS or polyglectin. End-to-end technique, approximate muscle end with interrupted horizontal mattress sutures. Either technique is acceptable. Use the one you are most experienced with. Bury surgical knots beneath superficial perineal muscles to minimize migration and discomfort. Overlapping or end-to-end repair of external anal sphincter is acceptable. Bury knots beneath superficial muscles. Repair of perineal body and vaginal epithelium. Reapproximate perineal muscles with interrupted 2-0 polyglectin suture. Close vaginal epithelium with continuous 2-0 polyglectin repeat suture. Approximate perineal skin with continuous subcuticle suture for less pain and gapping. Perineal body and vaginal epithelium should be repaired as separate layers. Final assessment. Perform rectovaginal examination to confirm complete repair and rule out retained swabs or instruments. Document all steps and completion of repair sheet. Documentation is mandatory for audit and follow-up. Post-operative management, broad-spectrum IV antibiotics intraoperatively, cephalosporins or clindamycin and metronidazole. Continue oral antibiotics for 7 days. Leave urinary catheter in situ for at least 24 hours. Prescribe stool softeners, that is lactulose, for 10 to 14 days to prevent straining and diacesis. Provide regular analgesia and NSAID ice packs. Daily perineal hygiene with water, particularly after bowel movements. Encourage pelvic floor exercises and refer to physiotherapy. Arrange follow-up with urogyne or specialist clinic at 6 to 12 weeks. Counsel patient on prognosis, symptoms to monitor, and implication for future pregnancies. Antibiotics, stool softeners, and follow-up are essential.
Very good.
Okay.
So in follow-up, you have to tell her regarding certain key percentages and outcomes. Okay, just tell her regarding that. Wait.
Okay, so now I'm going to tell you about some key percentages and their outcomes. Most of the patients that undergoes 4-degree perineal repair tear, under 12 months, 60 to 80% of the patients are asymptomatic. Wound infection occur in less than 5% with antibiotics. Wound diacesis occur in less than 5% with stool softeners. And anal incontinence and long-term occur in 10 to 20% of the patient. And need for further surgery is required in less than 5% of the patient. Am I clear so far?
Yes. Clear. Very good. And what you do at the end, clinical governance, 7 Ds.
Yes, debriefing and documentation. In the end, we're going to cover the 7 Ds of the clinical governance that include debriefing the team or to overview performance and identify areas for improvement. Document all steps, finding and post-operative instrumentation. Provide patient with detailed explanation and follow-up. Duty of condor, datics, drills, and documentation. This drill provide a comprehensive evidence-based approach to the repair of 4-degree perineal tear, including all surgical steps, post-operative management, RCOG guidance, and key outcome percentages.
So you're done with the teaching of perineal